Assalamu alaikum, this is Shamata Zara, and today my topic of discussion is atrial fibrillation. Now, I have made an old video on the atrial remodeling that occurs during the atrial fibrillation, so you can also look forward to that video. I'll share the link in the description box. So, starting with atrial fibrillation, basically, our first point which will come in our mind is that okay, what is atrial fibrillation? What is its definition? What do you mean by this word? So, atrial fibrillation is basically a disorder in which there is ectopic foci. Ectopic foci are formed within the atria, fine, and these ectopic foci they start to fire abnormal impulses that lead to abnormal rhythm of the atria as well as the ventricles. So this is basically atrial fibrillation, that ectopic foci are formed which lead to changes within the atria. Okay, now after reading this whole definition or listening this whole definition, the first point which comes in your mind is that what are the ectopic foci and how they cause this change in the abnormal rhythm of the atria and ventricles. So yes, now we will discuss the whole major pathophysiology that leads to atrial fibrillation. So this is now our pathophysiology. So first of all, first point which we will discuss is what are the ectopic foci. And before discussing ectopic foci, first point which will come in our mind is that how normal electrical activity occur in our heart. So if we know the normal, then only we can know how the abnormal things occur. Okay, so starting with the normal electrical activity of our heart. So imagine this is whole our heart divided into four parts. As we know, this is suppose the right atrium, left atrium, right ventricle, and the left ventricle. Now, in the right atrium, if I'll make it in green, this is the SA node, here is the AV node. So impulses originate from this SA node. Okay, so SA node is basically the pacemaker of our heart. So SA node is the this above one SA node is the pacemaker of our heart. It originate from here. Origination of the impulses occur, and these impulses then move through these pathways to depolarize whole of the atria, and then impulses are transferred to the AV node. Fine. So these impulses they move on to the AV node after depolarizing whole of the atria. So basically whole the atrial tissue they are depolarized only by the impulses or coming from the SA node. Fine. So this occurs, this all impulses they move on to the AV node, and from AV node here is present this fibrous band, this one, this is the annulus fibrosus. Fine. So this annulus fibrosus it basically act as an insulator. It doesn't allow leakage of electrical current from the atria into the ventricles. Fine. And here there is a gap or a space from where impulses can pass, that is the bundle fibers. So AV node impulse come to the AV node, and from there through these bundle fibers it moves on to the right and the left bundle branch, and from there it moves on to the Purkinje fibers. Fine. So this is all the electrical activity of our heart, how the normal heart, so we are talking about the normal here, how the electrical activity occurs within our normal heart. A brief overview, it originates from the SA node. From SA node, impulses move through three pathways to the whole atria, and from these atria, the final impulse come to the AV node. AV node sends impulses through the bundle fibers within the area present within the annulus fibrosis, and from there impulses they move through these two you can see these two green bundle branch fibers, right bundle branch and the left bundle branch, and from there to the Purkinje fibers. And remember, these Purkinje fibers they undergo the fastest conduction out of all these parts of the electrical activity of a heart. This is the bundle branch fibers. Okay, so this is our normal electrical activity. Now we will see that what is an ectopic foci and how this electrical activity becomes abnormal. Okay, now first of all talking about that what are the ectopic foci. Ectopic foci is, first of all you should know that our heart muscles they have a natural property of atomicity. Now what is this atomicity? That any of the muscle cell can act as a pacemaker. It has this ability that any of the muscle cell of the heart can act as a pacemaker. So this point will apply to understand the concept of ectopic foci. Okay, now what is ectopic foci? Basically, what is the meaning of ectopic? Any site that is other than the normal. Fine. So ectopic foci are basically small muscle cells of the atria which now start firing the electrical impulses and they act as pacemaker of the heart. They are called the ectopic foci. Fine. So the ectopic foci, its most common site is the left atrium, and more precisely in this left atrium its most common site is the muscle fibers that surround the pulmonary veins. Now I'll explain you this whole concept that what are those muscle fibers and why they act as ectopic foci. So look here. Suppose this is my right atrium and this is my left atrium. In this left atrium, 4 pulmonary veins open. We know it, there are openings of 4 pulmonary veins. Now imagine this is the pulmonary vein, it has to open in this heart tissue. So wherever a vessel has to open in a tissue, so these muscle cells they basically form a covering around it. They overlap it to provide it that space where it fits in the atrial tissue or the atrial muscle cells. Okay, so now these muscle cells that surround these pulmonary veins, these are the most common site where ectopic foci can develop. Now why? How to remember that this is that most common site? As we know that the electrical impulses within these muscle fibers, they are the the electrical impulses within these muscle fiber, its electrical activity, it is not considered important as compared to the depolarization or the repolarization occur within the other muscle fibers of the whole atria. So they are basically, you can say, the neglected cells and they're the neglected muscle cells. Now as we know that the neglect, as we know in our homes even very generally, that the neglected child of our house, it usually undergoes abnormal behavior. So just remember this simple line that whoever is being neglected, whoever is being ignored, it will show a very abnormal behavior. Fine. So here these are the neglected muscle cells, so they are the first site where, and the most common site more precisely, where ectopic foci will develop. Fine. So I think now your concept about normal electrical activity of the heart and the ectopic foci, and why they are the most why they are formed in the left atrium, and more precisely within the muscle cells or the fibers that surround the opening of the pulmonary veins. So I think this much concept is clear now. Moving on to the pathophysiology, or how the atrial fibrillation occurs, we are going to discuss that now. Okay, now imagine that this is, suppose, our heart. Again, this is the right atrium, left atrium, right ventricle, the left ventricle. Now we'll more important consider this left atrium. Imagine that, suppose, this is the SA node present here, this is the AV node. These are all the muscle cells of the atria. Some muscle cells are present here, some are present here. So imagine these are the muscle cells. Now this part of the heart, if you see this one, this has now undergone the ability to form abnormal electrical impulses, and more precisely this is the ectopic foci. Now what happens is that within our atria we have two sides from where the impulses are being generated. Originally it only generate from the SA node. These are the impulses, and these SA node, they will depolarize all of the atria, which is our normal basic concept. But in this case what is happening, that now impulses are being generated from the SA node, plus this ectopic foci, it is also generating impulses. Now look very clearly or very attentively, what will happen is that SA node fired impulses, these impulses, they depolarized this part of the atria. Now these muscle cells which are near to this ectopic foci, it will now no longer wait for the impulse coming from SA node. Why? Because it is receiving the impulses from this ectopic foci. They will pick up those impulses and undergoes depolarization and repolarization, hence contraction and relaxation occurs there. So what happens is, by the time the impulse comes from this SA node, these muscle group cells, group fibers or group of cells, they, suppose I mark it A, I mark this group of cells B, and this group of cells C. Now the A group of cells, they will now get depolarized by the ectopic firing from this ectopic foci, and by the time the impulse from SA node reaches here, they have already undergone one cycle of depolarization and the repolarization, and they then again get excited and again get contracted. Now what will be the result of this thing, that within our atria group of cells will form. Suppose this is a group of cells, this is a group of cells, this is a group of cells. Now different group of cells are formed within the atria, and these group of cells, what they do is they then contract and relax at different times. What does this point mean is that normally this whole atria, it is depolarized at the same time, it then contracts at the same, look at my hand, contract at the same time, generate the pressure and eject the blood into the left ventricle and right ventricle respectively. But in this case, since the group of muscle cells, they are working independently, so enough force will not be present, plus the synchronization is lost. Fine. So as a result, the atria will now be unable to perform its function properly. And what is the function of atria? Now what will happen in the atria because of all these changes? Atria's normal transport function of transporting blood into the ventricle is now impaired. What will happen is that the 20% of the ventricular filling that occurs because of active atrial contraction will not occur completely or is reduced. Fine. So as a result, two things will happen here. One, there will be pooling of blood within the atria. Fine. And secondly, because of this pooling of blood within the atria, the risk of formation of thrombus or clotting will increase. Now it is very important concept that in our body, wherever the blood is pooled, wherever the blood is undergoing stasis, is stopped somewhere, or its flow is reduced, there are very increased chances, increased risk of formation of thrombus and clotting to occur there. So this is a thing which occurs within the atria. Two problems: blood is being pulled up within the atria, thrombus or clot formation is occurring, and thirdly, the ventricular filling, 20% of the active ventricular filling is now not occurring sufficiently. Fine. So these are the three changes which occurs within the atria. Now talking about the ventricles. Fine. What will happen to the ventricles? They, now look here, they receive impulse from this AV node. AV node has to then send impulses to the bundle fibers and then to the Purkinje fibers and so on. This is the whole cycle. But here what happens is, since AV node is now stimulated by many of the impulses coming from SA node, coming from this ectopic foci at different times, not at same time. So what happens is that, one, atrial, of course, atrial contraction is increased. Now atria is contracting at a rate of 400 beats per minute, and these abnormal impulses, they then pass through AV node. Now what happens that this AV node, since it is, suppose this is that AV node, it is receiving so many impulses from so many directions throughout the atria, that this AV node, suppose it gets mad. Now when it gets mad, what happens is that it then start to fire increase impulses, in fact abnormal rhythm, abnormal impulses. Sometimes it send increase impulses to the ventricles, and sometimes it sends decrease impulses to the ventricles. Now what happens is that ventricles, they are, because of this problem, are not receiving impulses at a normal rhythm. Resultantly, the wave of the QRS complex that will appear on the ECG will be abnormal. Of course, sometimes it is contracting more, sometimes it is contracting less, because this AV node has now gone mad. It is receiving impulses from lot of directions and is sending impulses at an abnormal rhythm to the ventricles. So this thing occurs. Now because of this thing, what happens in the ventricles is that ventricles, they show irregular impulse. What they show is irregular impulse. Now we will discuss that what is this irregular impulse, what is its concept. Okay, now why it is called irregular impulse? That first of all, impulses are irregular. They are now coming at a higher rate than normal as they were coming before. So what will happen is that irregular impulses will come to the ventricles, and secondly, they are coming at irregular intervals in an irregular manner. So it is called irregular impulse. Now imagine this is, suppose, the ECG. These are the P waves, I'll tell you later, and this is the QRS complex. This is one QRS complex, this is two, then moving far away, then moving far away, suppose. Now this is the whole rhythm. Imagine how we calculate the rhythm is the difference or the interval between the two R waves. Now look here, there is very little interval, then here again a high interval more than before, then a more than before, again there is somewhat less, and so on. So irregular pulse would be present at an irregular intervals. That is why this impulse within the ventricles is called irregular impulse. Fine. this is a change which occurs within the ventricles. These were the changes which occur in the atria, and now these ventricles, they will start, of course they are stimulated more, tachycardia will occur within the ventricle, and now they will start beating at a higher rate. But this is an important point, that atria was beating approximately at as higher as 400 beats per minute. Now, question is within your mind, that will ventricles also contract at this much high rate? So no, your answer is no. Why no? Because when the impulse is passing from the atria to the ventricles through the AV node, a lot of impulses, they are cancelled. They are not allowed to pass through this AV bundle down here. So only few impulses reach here to the ventricles. So the ventricular rate is as high as 75 to 175 beats per minute. But of course, it is tachycardia. It is a higher rate, irregular impulse within the ventricles. So this was the whole pathophysiology of the atrial fibrillation, how atrial fibrillation occurred, how it will bring in changes within the atria and ventricles. This is all. Now when we have a good understanding about how the disease occurred, what is its pathophysiology, now we can very easily, in fact you listening this video can easily tell clinical features, that what will the features the patient will present without even reading your books. So come on, let's discuss what are the clinical features with which the patient will present, how we'll pick up scenarios, how we will diagnose a patient with atrial fibrillation. So let's discuss what are the problems that the patient is facing, what are the changes that occur within the heart, and as a result, resultantly we'll find out the clinical features. So first point, of course, starting from the atria. Atria में we are having two major issues. One is there is pooling of blood in the atria, which lead to increased risk of thrombus formation. Fine. So first clinical feature would be related to this thrombus. It will come in your mind that when there is a thrombus and it breaks down and becomes an embolus, then this embolus can block any of the artery of our heart, particularly the arteries supplying our heart, our brain. Fine. Which will lead to a very emergency condition, ischemic stroke. So patient can have ischemic stroke, or because of this embolus blocking any of the systemic artery will lead to systemic thromboembolism. Now when it will block any of the systemic artery, then depending on that artery and which organ it will supply, infarcts will form in that organ, resulting of blockage of the artery. This is one clinical feature. Secondly, we've already discussed that this atria is not now contracting. Its transport function is reduced. So the blood reaching the ventricles is reduced. Fine. So the blood reaching the ventricles is reduced. Now when the ventricles are receiving less blood from this atrial contraction, so normally I'll just explain you a thing of the how diastole occurs. There are three phases of diastole. This will help you in the understanding this concept. So first phase, in the second phase, and then the third phase. These two phases, they occur passively. Fine. These are the two phases of diastole which occur passively. They do not require any atrial contraction to cause transfer of blood from the atria to the ventricles. Fine. So and they almost transfer 80% of the blood to the ventricles. Now this remaining 20% of the blood is by active contraction of the atria. Now in this disease, look that the atria is abnormal, it is not able to pump this extra amount, extra 20% of the blood. So in normal condition, when patient is not having any stress, or patient is in normal conditions, then what happens is that this 80% of the blood is sufficient and the patient will be asymptomatic. What will the patient will be? Patient will be asymptomatic. But once he'll undergo exercise or any increased stressful conditions, then what will happen, that the patient will have symptoms of atrial fibrillation. So coming back here, blood reaching the ventricles are reduced, so as a result the stroke volume is reduced, ejection fraction to some extent is reduced, which will lead to less oxygen reaching the tissues. So as a result, the feature that patient will present will have fatigue, exertion intolerance. Fine. So these are the features which the patient will present very easily. First of all, talking about atrium, we have two problems. One is pooling of blood, thrombus, embolus formation. It will lead to a condition called ischemic stroke can occurs in the patient. Patient can present with ischemic stroke, systemic thromboembolism. Then since its transport function is not occurring well, this extra 20% will not be supplied to the body and not to the ventricles, and instead eventually not to the body. So the patient will have fatigue since the low oxygen is reaching the muscle cells or the body cells, exertion intolerance, even angina can occur. Fine. So these are the features which will present. Now because of the ventricles, symptoms can also be because of the ventricles. Fine. So since ventricles are now beating at a higher rate than normal, so now the ventricles are now beating at a higher rate than normal, so what features will be present within the atria? That first of all, within the ventricle, first of all, the ventricles, because of it, the clinical features can be tachycardia, palpitations can occur in the patient, and the heart rate and the rhythm of the heart, they will be abnormal. So these are the clinical features which will be seen in that patient of atrial fibrillation. Just a brief overview of the whole topic we discussed: pathophysiology of atrial fibrillation and the causes of atrial fibrillation. So brief overview of the whole topic. What is atrial fibrillation? Atrial fibrillation is that ectopic foci are formed within the atria, and these ectopic foci, they then start to fire abnormal impulses, leading to abnormal rhythm of the atria and the ventricles. Within the pathophysiology, because of the ectopic site, its most common site is left atrium, and more precisely, most common site is the muscle fibers of that surround the pulmonary veins. So that is the most common site. And what happens within the atria, that atria are now beating at, this is a very important line to explain whole the concept, that now because of atrial fibrillation, atria are beating rapidly, they are contracting rapidly, but in ineffective and uncoordinated manner. So this line is very important, that the atria, they are beating rapidly. No doubt they are beating rapidly at a higher rate than normal, this 400 beats per minute, which is very high, but they are beating uncoordinated, in an uncoordinated manner. And since they are not coordinated, imagine the same thing which occurs normally, that if we work together, we have a very good output, as compared to same work is done by individual people, no coordination is present within them. Same occurs within the atria, that atria are beating no doubt at a very rapid rate, contracting more, but they are ineffective and uncoordinated manner, that they are unable to perform their function properly. Fine. So atria, their transport function is not performed correctly, and as a result what happens is that blood start to pool up within the atria and increase risk of thrombus formation. Atrial rate is increased. As a result, abnormal impulses they then transfer from AV node to the ventricles, leading to ventricular tachycardia as high as 75 to 175 beats per minute. Ventricles within the ECG will see that there is an irregular impulse because of the all this scenario. And one point which I've missed is that because of this atria, since they are contracting and relaxing more than normal, so on ECG what we'll see is that we'll see on the baseline oscillation very few contractions and relaxation, contraction and relaxation. We see multiple because now normally one big P wave is formed in normal condition, but in atrial fibrillation what happens is that multiple small baseline oscillations will be present on the ECG. It is a diagnostic point of atrial fibrillation. Fine. Then comes the clinical features. The clinical features may patient will have pooling of blood within the atria. This pooling of blood will lead to increased risk of ischemic stroke. Patient can have systemic thromboembolism because of the decreased supply by the ventricles, angina, fatigue, exertion intolerance that can occurs, plus ventricle tachycardia, palpitations, abnormal rate, abnormal rhythm. These will be the clinical features which the patient will present. So this was the brief overview of atrial fibrillation. I hope you understood the whole point which I tried to explain you. Please like, share and comment on the video and subscribe my channel. I hope you like it, and thank you so much. Allah Hafiz. See you in the next video.